I'm Dr. Fakir Raveri, and this is Thyroid Disorders in Adults. Alright, so day 2 will focus on hyperthyroidism. At this point, you should know the basics, but let's review some basic definitions. So, thyrotoxicosis refers to clinical syndrome of excess circulating thyroid hormones. This could be excess hormone for various reasons. But when we say hyperthyroidism, we specifically mean when there's increased thyroid hormone synthesis and secretion by the thyroid gland. And of course, we have the medical emergency of thyroid storm, which is the severe thyrotoxicosis. So all the symptoms of hyperthyroidism will be in their extreme form. Here's a list of your reliable resources, just like before. American Thyroid Association has several guidelines, including one for hypothyroidism, one for hyperthyroidism, and also one guideline dedicated to management of pregnancy. The first learning objective is assess the values of thyroid function tests in a patient with hyperthyroidism. So here are the laboratory tests that are available for assessment of hyperthyroidism. The most important test is the TSH. So again, you do not need to memorize the normal values for these. But for TSH, when it comes to hyperthyroidism, TSH will be decreased. Obviously, in hyperthyroidism, your T4 levels will be high, which will have a negative feedback on the pituitary gland. So therefore, TSH levels will be low, lower than reference range. So definitely decreased in primary hyperthyroidism. There's also the condition of subclinical hyperthyroidism, in which case TSH is also decreased. However, in subclinical hyperthyroidism, your T4 levels will be normal. We use both TSH and T4 for diagnosis and monitoring of hyperthyroidism. In addition, when it comes to hyperthyroidism, we also look at T3 levels. Specifically, we have labs to measure total T3, which will be increased in primary hyperthyroidism, what will be normal in subclinical subclinical hyperthyroidism. So, in subclinical hyperthyroidism, both T4 and T3 will be normal. But TSH will be decreased. Now, because the most common cause of hyperthyroidism is Graves' disease, we use TRAB or TRAB to confirm diagnosis of Graves' disease. Now, its routine measurement is not mandatory, but if someone wants to confirm that someone's hyperthyroidism is due to Graves' disease, they will measure thyroid receptor antibody. Lastly, we have something referred to as radioactive iodine uptake. Again, you don't need to know the reference range for these, but if the radioactive iodine uptake is high, it indicates that there's endogenous hyperthyroidism. That means that the thyroid gland is producing thyroid. So if you give if we give the patient radioactive iodine, we can actually measure it in the in the thyroid hormones that are produced. So if that same iodine that we administered ended up being in the hormone, that means that the thyroid is overproducing the hormone. Therefore, any iodine that you give, it will actually use to make more hormones. Now, if the value is actually low, in the absence of iodine excess, and it will indicate that there is no thyroid gland hyperfunction. So if that's true and the patient has hyperthyroidism, it's most likely due to thyroiditis or hormone ingestion. So for example, if someone overdoses on levothyroxine, that would cause hyperthyroidism. Now here's the algorithm for identification of primary hyperthyroidism. So as I mentioned, the first thing you need to check is TSH or TSH and T4. Of course, anything I say about T4, you can also apply to T3. So if the TSH is normal, of course, and T4 is also normal, we will refer to it as euthyroidism. So in a normal person without thyroid disorder, you will have euthyroidism, and also in patients who have thyroid disorders, the goal would be to achieve euthyroidism by intervention. Now, if the TSH is actually low, and if the T4 is elevated, that indicates primary hyperthyroidism. So obviously the T4 level is high, so it means hyperthyroidism. And then because the TSH is low in response to the high T4, that indicates the problem is in the thyroid. The problem is in the thyroid gland, so it's primary hyperthyroidism. Now, if the TSH is low but the T4 is normal, we refer to this as subclinical hyperthyroidism. And of course, if both TSH and T4 are low, because T4 is low, we call this hypothyroidism. And because normally, if you have hypothyroidism, TSH is supposed to be elevated, but in this case, it's not. That means this is not a problem in the thyroid gland. So this is central hypothyroidism. Now, here are some key recommendations from the 2016 American Thyroid Association guidelines. So one recommendation is that, of course, anytime you have thyrotoxicosis, the cause or etiology of it should be determined. That's why we use the radioactive iodine uptake to identify what's really causing it, whether it's thyroid gland hyper function or not. We can also, confirm Graves' disease. So it's really important to know what's causing it. And then diagnosis is based on clinical presentation and also initial biochemical evaluation. So by initial biochemical, they're referring to your TSH, T4, and T3 levels. And then they say if the diagnosis is not apparent based on number 2, then you should really check the thyroid receptor antibody, or you can also do radioactive iodine uptake. And beyond what we need to know as pharmacists is, basically the doctors can do ultrasonography to study the thyroid in more detail. The next learning objective is given the Birch and Wartowski score for a patient, determine the likelihood of thyroid storm. So basically, these two authors came up, with a scoring system, which consists of, for example, body temperature, central nervous system symptoms, GI symptoms, cardiovascular symptoms, whether the patient has, congestive heart failure, and a few things. So you don't really need to memorize all of this, but what you really need to know is when someone uses this tool and calculates a score for a patient, what does that score mean? So what you need to know is if out of this you calculate a score of 45 or greater for a patient, that means that the patient is likely to have thyroid storm. So this score is something that they use in the emergency department. So when somebody comes into the emergency department, with symptoms of hyperthyroidism, they need to know, how urgent is this, because treatment will be more aggressive for thyroid storm. So they will, they look at all these things that are listed in this table, and they will add up the score. So if it's 45 or greater, that means they most likely have thyroid storm. So they will start treatment aggressively. Now, if the score is 25 to 45, it's impending storm, so it may be like, it might be a storm, in development. So it's up to the clinician. So you can either treat aggressively, or you can just monitor more closely. And a score below 45 is unlikely to represent a thyroid storm. I will talk about the treatment of thyroid storm later in this activity. The next learning objective is given a patient with thyrotoxicosis, recommend guideline concordant pharmacologic therapy. So again, back to the 2016 American Thyroid Association guidelines. So here are some key recommendations. So basically, they're saying anytime the patient has symptoms, and because the thyroid hormones will act on the cardiovascular system, um, anytime someone has symptoms which will make the patient very uncomfortable, uh, you need to use beta adrenergic blockade. So basically, beta blockers, because it will counter the effect of thyroid hormones in the heart. So that's one of the recommendation. Next, they say, since Graves' disease is the most common cause of hyperthyroidism, so just, these recommendations are pertaining to Graves' hyperthyroidism. So they say, you basically have three treatment modalities. One is giving the patient radioactive iodine. Another, which was the focus, the most important for pharmacists, is anti-thyroid drugs. So, we definitely need to know these drugs. And lastly, thyroidectomy. So basically, they will, either remove a portion of the thyroid gland, which is referred to as hemithyroidectomy, or they can actually remove the entire thyroid gland, because the symptoms of severe hyperthyroidism can be life-threatening. So, for some patients, they may need to remove the entire thyroid gland. Next, they say, anti-thyroid drugs have side effects. So, if you are to start those, the patients need to know the side effects. So that's where the pharmacists come in. So the patients really need to know all the side effects, because we have other treatment options. So some patients may choose to say, well, this, I really don't want to have these side effects. So, if you want to take out my thyroid gland, that's a discussion to have with the physician. And then they can evaluate the risk versus benefit and see if that's an option. Or they can choose to have, radioactive iodine. And of course, there are like, contraindications to each treatment modality. So, with the discussion between the patient and the physician and the pharmacist, then the right modality can be decided for the patient. But nonetheless, it's important to discuss the side effects of these drugs to patients. Next, number 4, I have before starting anti-thyroid drugs, and at each subsequent visit. So, when patients are on these drugs, they need to follow up, with either with the physician or with the pharmacist at an ambulatory care clinic. It's important to each time to educate the patient, let them know to alert to be alerted if the symptoms occur, stop the medication, and call their physician immediately. Now, some patients may have allergy to some of these anti-thyroid drugs. In general, it's not recommended to use an alternative once if someone has allergic reaction, because there's cross reaction. So if someone has allergic reaction to one drug, it's likely that they will also have that reaction to an alternative drug. So now it's Methimazole is one of the drugs that's first line for use in hyperthyroidism, and its duration of therapy is typically 12 to 18 months. However, so after 12 to 18 months, the decision is to be made to whether stop the treatment or continue. So one of the things that the guidelines recommending is to actually measure thyroid receptor antibody before stopping. And if it's undetectable, the patient has higher chance of remission, or not relapsing into hyperthyroidism again. But if after 12 to 18 months, if thyroid receptor antibody is still detectable, then it's advised to continue continue further beyond 12 to 18 months. Also, once 12 to 18 months is complete and the patient still has hyperthyroidism, that's, obviously the anti-thyroid drug, hasn't been working, so that then they recommend to use the other two treatment modalities. So either radioactive iodine or uh, thyroidectomy. Now, uh, here are the common beta blockers that are used when it comes to hyperthyroidism. So propranolol, and for these you don't need to memorize the doses, but you do need to know how they help in hyperthyroidism, and which one to avoid in pregnancy. So propranolol is a non-selective beta blocker. When we say non-selective, that means there are different beta adrenergic receptors such as beta 1 and beta 2. Beta 1 happens to be selective, cardioselective, as in you only find it uh, predominantly in the heart. So the reason we are using beta blockers is actually to prevent those symptoms, that the cardiovascular symptoms. So it's important to know that when you do have non-selective beta blockers, they also block beta 2 receptors that are typically found in the lung. So if someone has pulmonary issues, it's best to avoid this and stick to something that is beta 1 selective, because for example, when someone has because what beta 2 does in the lung is that it dilates, so it will help with breathing. So if someone has breathing problem and you have a beta 2 blocker, it can cause problems in the lung. So anyway, if someone has a history of pulmonary disorders, it's best to avoid non-selective beta blockers and use something that's beta 1 selective. So propranolol happens to be non-selective, so it will help with symptoms of with cardiovascular symptoms. So for example, if someone has tachycardia because of the effects of thyroid hormones, it will help by blocking the beta 1 in the heart, so that person will not feel palpitation. Another thing that propranolol can possibly do is that it may block T4 to T3 conversion at high doses. So typically around 40 milligram, and that's one of the reasons we may use it 3 to 4 times a day. The more you have, the more likely that it will block T4 to T3 conversion. So we're talking about hyperthyroidism. So if we block that conversion of T4 to T3, and remember that T3 is more potent than T4, so that would actually help with the symptoms as well. Now, you may ask, well, why not just use beta 1 selective than non-selective? So when it comes to pregnancy, propranolol is actually preferred. Propranolol is, we have the most clinical experience with it. It's the oldest beta blocker that's been used in hyperthyroidism. So we have a lot of data with it, and we know that it's compared to other beta blockers, we're more comfortable using it in pregnancy, including during nursing. Now, atenolol is beta 1 selective. Now, one thing, so I did mention with propranolol, if you dose it 3 to 4 times, that's really hard for the patients to adhere to. So if you just think about it, if you have to take a drug 3 to 4 times a day, that's very inconvenient. But if you had to take something like once a day, like nadolol, that's a lot easier to remember. Like you just take it once a day, whereas 3 to 4 times a day is very inconvenient. So anyway, so because atenolol you can also take it once or twice a day, it increases patient adherence. However, if the patient is pregnant, it should be avoided. So pretty much most beta blockers are pregnancy category C. Atenolol happens to be pregnancy category D, so the guideline actually says to avoid it during pregnancy. Now, this is not an absolute contraindication. It's not category X. If it's category X, you definitely should not use it uh, during pregnancy. But category D, especially if we have safer options like category C, then you should definitely during pregnancy try to avoid atenolol. Next, we have metoprolol. Note that metoprolol comes in two forms. One is tartrate, which is short-acting, and one is succinate, which is long-acting. So if it's long-acting, it can actually be dosed once a day, whereas if you use tartrate, it needs to be dosed at least 2 times a day. Metoprolol is also beta-1 selective, and it's pregnancy category C. Now, it's never been shown that metoprolol can block T4 to T3, so that's why we still prefer propranolol because it can convert T4 to T3. With atenolol and metoprolol, it hasn't really been shown. Now, nadolol can also block T4 to T3 conversion, but it also happens to be a non-selective beta blocker. But it is dosed once a day, so it makes it easier for patient to be adherent to. Now, I haven't seen this in clinical practice more than propranolol. I think nadolol is actually more expensive than propranolol. That may be the reason you may not see this frequently, even though it's easier for patients. And then lastly, when it comes to like thyroid storm and emergency, you need something. The patient may not be able to take oral medication. So esmolol is something that we can actually do continuous IV infusion. So we will do, and anytime you do continuous IV infusion, that means that's a very large dose. So the patients need to be closely monitored. So this is typically done in the ICU. Another thing that I forgot to mention about nadolol is that we actually have the least experience with nadolol, whereas with propranolol we have the most experience. So that's also another reason you will most likely see propranolol in practice and not nadolol. Now, here are the 3 treatment modalities that I mentioned to you. We will focus on anti-thyroid drugs, as pharmacists. So here are the 3 anti-thyroid drugs. Only 2 of them are available in the United States. So propylthiouracil and methimazole are the 2 anti-thyroid drugs that are available in the United States. They will both inhibit thyroid peroxidase, which will basically block thyroid hormone synthesis. Propylthiouracil, in addition, can also block T4 to T3 conversion. When it comes to adverse effects, they both have similar adverse effects. Most commonly, skin reactions like rash and pruritus. They can both also have hepatotoxicity, but when it comes to hepatotoxicity, propylthiouracil actually has a lot higher rates of hepatotoxicity, which happens to be a black box warning for propylthiouracil. So because of that black box warning, methimazole is considered preferred initial therapy for everyone, except if when someone is pregnant during first trimester, propylthiouracil happens to have less adverse effects on the fetus. So during first trimester, propylthiouracil is preferred, and then as soon as the pregnant patient enters the second trimester, we will switch back to methimazole because that increased risk of hepatotoxicity with propylthiouracil. Note that these 2 are both dosed once a day, so that's easy for adherence. There's a high risk of recurrence after treatment has been withdrawn. So it's really important for the patient to finish that 12 to 18 months. and about like half of the patients will actually maintain remission. Now, it hasn't been shown that if treatment is extended beyond 18 months, it doesn't really decrease the rate of recurrence. And also combining anti-thyroid drugs with levothyroxine, which is considered a block replace regimen, is also not been shown to decrease recurrence rate. Now here the American Thyroid Association guideline recommendation for pregnancy. So like I said, in pregnancy, PTU is preferred during first trimester, and then we switch to MMI or Methimazole. Alright, so when it comes to thyroid storm, here are the recommendations from American Thyroid Association. So basically, they do tell you to use the Birch-Wartowski point scale, or BWPS. So if it's 45 or greater, it's likely to be thyroid storm. Now, these patients happen to be very symptomatic. So, and one of the symptoms is that the patients will be, the temperature will be elevated. So in addition to beta-adrenergic blockers, anti-thyroid drugs, inorganic iodide, and corticosteroid, we'll also need to cool the patient either with Tylenol, acetaminophen, or cooling blankets. Now, when it comes, so this is basically kind of thyroid hormone-induced fever. So that's why they're using acetaminophen or APAP. It's important to only use Tylenol and not NSAIDs. So it's absolutely not okay to use NSAIDs, because what NSAIDs do is that they will dislocate protein-bound thyroid hormones. So remember, thyroid hormones are mostly bound to protein in circulation. So what NSAIDs do is that they bind to those proteins, and by doing so, they will replace, or I should say displace, they will displace thyroid hormone. So they will actually increase the free thyroid hormone in the blood. So someone who's having a thyroid storm, which is an emergency, that can be life-threatening. So it's not. So you should avoid NSAIDs for cooling the patient. So only Tylenol or cooling blanket. Now here are the drugs that you already know, but we just use them more aggressively. When it comes to thyroid storm, one thing that we also use is iodine. So potassium iodide is what we typically use. It's recommended to give the anti-thyroid drugs first, and then wait an hour later and then give the iodine. It's also important to give the patients hydrocortisone. This is just to make sure the patient doesn't have adrenal insufficiency. You will learn about adrenal disorders next week. The last learning objective is design a monitoring plan for a patient with hyperthyroidism receiving treatment. So again, here are the key recommendations from the American Thyroid Association guidelines. So basically at baseline, before you start treatment, it's very important to get a baseline complete blood count, or CBC. We call this CBC, which includes white blood cells, platelets, hemoglobin, hematocrit, and this is because one of the rare side effects of anti-thyroid drugs is agranulocytosis, which means that it will block your cell lines, affecting your white blood cell. So it's important to measure that at baseline, because later on, when the patient has a very low white blood cell, you want to know if it's due to other reasons, or is it the thyroid drugs causing it. So that's why you need to know the number white blood cell at baseline, and then once you start treatment, you will monitor it to make sure that it's not the drug dropping it. It's not a common adverse effect, but it's a serious adverse effect because white blood cells are part of your immune system. So if someone's white blood cell starts to drop low, then that means they are exposed to infections. Now, because of the hepatotoxicity, it's also important to measure, liver function and hepatocellular integrity at baseline. And during treatment, especially if the patient is experiencing any side effects such as skin adverse effects, as well as if the patient has dark urine, has joint pain, abdominal pain, nausea or fatigue. Now, when it comes to, one important monitoring parameter is adverse effects. So at each visit, we should ask patients what adverse effects they're having. Obviously, if it's a serious adverse effect, they will have to stop the treatment. For more minor side effects, such as, skin rash, or, it's recommended to use an antihistamine to manage that side effect and continue treatment. Now, if that minor adverse effect becomes persistent, because it can affect the quality of life of the patient, especially since we're going to treat them for a very long time, 12 to 18 months, then it becomes, an issue. So then we need to figure out which drug is causing it, and then we can actually consider alternative treatment, like one of the three treatment modalities that I mentioned earlier. If the patient is persistently having side effects, then they may go to one of those modalities like surgery or radioactive iodine. And of course, for monitoring the thyroid disorder itself, hyperthyroidism, it's important to continue to monitor free T4 and total T3, and it's typically done in about 2 to 6 weeks after initiation of therapy to make sure the patient is responding. Once the patient, so like I said, the goal is to get the patient to euthyroidism. So once the patient is euthyroid, the dose of methimazole can usually be decreased, because think about it. If the levels continue to go down, the levels of T4 continue to go down. Once it's euthyroidism, you want to lower the dose to make sure that you don't cause hypothyroidism in patients, because you want to maintain them in euthyroid state. So that's why once they hit euthyroidism, we typically decrease the dose by 30 to 50%, and then we measure the T3 and T4 4 to 6 weeks after that, and then repeat it in 4 to 6 weeks. Here's a case study. So let's say we have a 63-year-old female with Graves' disease. Her thyroid laboratory value include the following: so TSH of 0.1 and free T4 of 3.5. The question is, which thyroid disorder does she have? So choice A is primary hyperthyroidism, B is primary hypothyroidism, C subclinical hyperthyroidism, and D central hyperthyroidism. So when we look at the T4 level, we see that it's 3.5, which is higher than the normal range. So this is definitely not hypothyroidism. So choice B is wrong. So it is hyperthyroidism. Because TSH is lower than normal, so at 0.1 is lower than 0.5, this is actually primary hyperthyroidism. In order for the patient to have subclinical hyperthyroidism, the T4 needs to be normal. So let's say if the T4 was 1.2 and TSH 0.1, then you will have subclinical hyperthyroidism. And in the case of central hyperthyroidism, you would have a T4 of 3.5, and then TSH would have to be greater than 4.5. So now that we know what the patient has, which would be considered the best drug for initial treatment for her condition. Now, this we don't have any information, and especially at 63-year-old, this patient is unlikely to be pregnant. You know, so the drug of choice for non-pregnant patients in their first trimester would be methimazole. So methimazole would be the right answer. Amiodarone is not used for treatment of hyperthyroidism. It can lead to hyperthyroidism, but it does not treat it. Propylthiouracil would be drug of choice if this patient was pregnant and in their first trimester. And of course, levothyroxine is used for hypothyroidism. This concludes this presentation.